So what were we talking about a moment ago? I think, Claire, you were telling us about the traditional view of therapy and how that works.
That's right. So from a therapy point of view, traditionally, for many years now, therapists have got involved at the latter end of the patient journey. And I think a lot of that is down to resource and teams becoming more and more stretched. And so the focus certainly from an occupational therapy point of view, has been more around assessment for discharge rather than anything else. So rather than engaging people from an earlier stage in activity or occupation at ward level, it's purely been at the board round when someone said we need a referral to OT, the OTs then pick the patient up and assess them for discharge, and that's tended to be when the patient's been medically fit. So you can imagine patients could have been in for quite some weeks until that point, and so you can imagine actually the level of dependency that patients have actually got to at that point as well. So you're almost fighting against a losing battle, if you like. So you're dealing with a patient that's deconditioned, but you also don't know anything about the context of the person either. So actually the therapist at that point has then got to start to backtrack and understand actually about the person at home. And so there's often lots of phone calls, lots of communication with family members, with the patient themselves around how were you managing before, what help did you have at home, what equipment do you have at home, what were you doing, what was your routine like, whereas actually we could have done something different and found that out up front at the very earliest start of the patient journey. So you can imagine the time that takes, and actually the person that you're seeing in the bed is one that's very different to often what is described by the patient from how they were managing at home previously. And that's when you get statements like they're way off their baseline, and we start to then use intermediate care or bed-based rehabilitation to get people back to baseline in order to go home, which actually we're rarely going to achieve, certainly in the older person who's deconditioned for a period of time in hospital.
So where do you find that information from?
So the information about the context of the person is often just from phoning relatives and carers. It depends upon the person, but really going back through the notes as well, trawling through to see actually what was happening beforehand, if anybody's documented anything. But it was often rare that any of that was documented. So it's a tricky one to find really, and depends on the patient. So often it's an unreliable source of information. Actually, scrap that. I didn't like that.
There's so much information though, isn't there? There's so much information when a person comes into hospital, because they probably have been supported for many weeks or months before they had a crisis in their health. There's so many people with information, family, neighbours, other healthcare and social care professionals, that we often don't ask those questions. We don't ask those people.
No. Community matrons, the nursing teams, all of those people that are going in to see people at home, but very rarely any of that actually translates into the hospital environment, which is so sad, because the hospital episode is such a small period of time in comparison to the life at home. And I think we need to start thinking more about that we've borrowed the patient from community rather than actually this is the be all and end all, that they're here in hospital.
On a big piece of elastic.
Absolutely.
Yeah. What about the ambulance teams? They see the patients in their home environments.
That's right, and so often when we've engaged with them, they give us loads of really meaningful, helpful information, but it's not something that naturally kind of happens. But once we start asking the question and starting the conversation, my experience is that actually they've really wanted to talk to us and actually wanted to pass the information over, and a lot of them have said how good it feels to actually be able to tell somebody about the patient and the context of the person, not just about the clinical signs and symptoms that they're seeing of the patient as well.
I suppose some of that is about recognising that this information is important, not just for that episode of care, but also in terms of returning the patient back home again.
Of course it is. It's really critical in terms of understanding how we can get people back home, because often people are admitted, let's be honest, for a minor clinical illness, but actually for a major functional deficit. But actually we can often compensate for those type of things in the person's home, but actually if we don't know about the person's home circumstances or environment, it's more of a struggle to do that.
So what's stopping that sort of passage of information then? What's it about that environment that's preventing that passage of information?
I think it's about the clinical handover area itself can sometimes be quite chaotic, as you know. It's a very busy area, and it's a very clinically focused area because people are often, they're unwell, that's why they're there. And so there's a real focus on the clinical signs and symptoms rather than the whole person. And that's something that I think, we can really miss a trick if we don't start to ask those questions about the person from the person themselves and really find out about them, not just about what they're experiencing experiencing clinically at that moment in time.
Because we don't actually talk to, I've observed, that sometimes we don't talk to patients very much at all during that critical spell of their illness, when actually they're probably more frightened and they're on the trolley sort of being, the handover's occurring, and actually we don't actually often speak to the person, and actually asking them about general stuff and how they're feeling and how they've been at home might be comforting as well as really important for them to be talking about at the time, as much as their sort of risk of sepsis, etc. I think that's really critical.
It's a really good time, to start giving those messages around it's okay, we're going to get you back home as soon as we can. It's about building that in so that the expectations aren't raised that actually they're going to be admitted into hospital. It's about giving those home messages all the time. It's really reassuring for them to hear that.
Because sometimes information can be less useful, can't it? Not blaming anyone, but say a member of the ambulance service came in and said that the patient's home there was hoarding or there was infestation or signs of neglect. Sometimes that information without any other detail can actually be a barrier to somebody going back home, can't they? And actually when you find out there might be a little bit of a problem in one room or a little bit of a problem outside next to the bins, but actually the person is quite safe to go home, but we sometimes use that as a sort of a way to go, actually it's not safe for discharge.
That's so true. It can be really detrimental really for the person and can literally keep them in hospital because, as you say, that little bit of information then grows with the patients as the weeks go on, and it becomes a barrier to them going home. So patients will await for house cleaning, etc., etc. So it absolutely is right about understanding the reality, not just something that's been dropped into a conversation. So it's being able to delve that little bit further to find out more information about that.
So just checking back in now, you mentioned earlier that the traditional view was at the end of a patient's stay, and slowly it seems like you're coming forward through the pathway to gather the information nearer its source. Is there any other people or any other type of information that would be useful to you from the ambulance crews or the ED nursing staff?
It absolutely doesn't matter who collects that information. It's about having an interest in the person, it's about having that conversation with the person and finding out what they value and what's really important to them. And then the critical thing is about how that information then travels with the person, so that the person has not only a clinical journey, but they also have a functional journey as well. So it's valuing both of those things at one time, rather than just looking at managing the clinical condition. So it doesn't matter which professional collects this information, as long as they understand the relevance of it in terms of admission avoidance or actually starting the discharge from that moment in time. It's really, really important that we do that, because if we do that, then we can most likely reduce length of stay and we can reduce the number of patients that actually get admitted into hospital. So how important is that for the person in terms of the outcomes that we can achieve?
It'd be really good to hear about some examples of good practice, Claire.
So the first time I heard about therapists being at ambulance handover and collecting this type of information was actually in Brighton, and it was some years ago now, but they were the first people to actually do this with really, really great results. They also redesigned their therapy team so that the therapists that were actually at handover also saw patients on the care of older people wards as well. So they kind of redesigned their whole service to actually accommodate this way of working. So they were the brave ones, the pioneers if you like, who actually sort of turned it around and flipped over their patient caseload, so started the patients from the very front door from that very moment, rather than later on in the patient journey. So that was kind of the building of the evidence base, if you like, which took it to other places around the country.
So asking those questions that we talked about, but also asking the ambulance crew that are handing over the patients some important questions as well. So it's actually gathering it right at that point.
It is. It's actually being part of the team ambulance handover. So you're able to see the patient, talk to the patient, but also, as you say, talk to the paramedic who's handing the patient over, to ask, how did the patient transfer onto the trolley? How did it appear they were managing at home? Have they got a care package? Do you know the name of the agency? So it's getting into some of the detail, and actually, interestingly, the more that we ask those questions, the more that actually the crews appear to have that information, so they come with it in hand ready the next time round, because they feel assured to be able to hand that information over, because they know we're going to be able to do something with it.
And they may not have written that down in their handover notes, but actually when you prompt them by asking a question about maybe what did the kitchen look like, where was the person when you found them, those sort of things. They go, oh yes, it's
That's
really
right.
important
It
I
all
tell
fits
you. Yeah.
and gives us a really good picture of how the person's been managing at home. So really, really helpful.
So they were starting to understand not only to collect the information, but recognising how important it was for the patients the rest of their journey. What were the benefits of having that therapist at the front door? You mentioned evidence that links that.
So really, if you're collecting that information up front and you're not doing that later on once the patient becomes medically optimised, then actually you're taking days, if not weeks, off length of stay, because your assessment has already started. You've already commenced it there and then. So you actually know where you're aiming for. You can almost think about actually this person's likely to be able to go home, because knowing the clinical condition they've come in with, but also marrying that with their functional level, actually we can absolutely aim home for this person. So it really, really helps in terms of the planning, because it just all falls into one at that one moment in time, rather than waiting till later when you're trying to put lots and lots of pieces of information together.
And does it need to be a therapist? I mean, a therapy model, an MDT model looks like that's great, but if that's not, if you've not got the workforce, which we know a lot of sites don't have that sort of workforce, it doesn't need to be a therapist. I mean, not
absolutely doesn't. It doesn't need to be a therapist. It just needs to be somebody who understands why they're asking those questions. So really understanding what are they then going to do with that information to make sure that it's not lost in a set of case notes or on a system, but actually it stays with the patient and actually informs whether they actually get admitted or not, or actually starts the discharge plan from that moment.
So the ratting nurse, or the nurse that's sort of doing that rapid assessment and treatment, they're senior nurses as well. So
that's right.
And how are they gathering that information? It's sort of a conversation.
It is. It's purely a conversation. It's quite an easy conversation to have, because it's just finding out about the person. And so obviously once they're having that conversation, they can look at the person clinically as well. So it all kind of goes together and fits quite neatly if we start to open our eyes to that aspect of the person as well as the clinical picture.
Yeah, great. Conversation that probably a lot of ambulance crew have with the patient, in the back of the ambulance, and
Yeah, I think that's where paramedics and certainly therapists are aligned. They see the person in their own environment. They treat in terms of that own environment as well, I suspect. Is there any other information that'd be useful to you that you can gather from the ambulance crews, Jo?
I think it's about just making sure, because every person's different and every environment's different, so it's making sure that the crews are conveying the patient but with home in mind. So they're thinking ahead, thinking actually if we're going to take this person to hospital today, we're doing so for a reason, but actually hopefully the hospital can turn them back around and they can come back home today. So do they have the keys? Have we given them the name of the phone number of the agency? Have we got the detail that they need in order for them to do that?
So we're designing their journey home on the way to hospital.
Absolutely.
Brilliant. Claire, you mentioned how important the information is. You then identified the places where you can get that information. How do we remain mindful of the importance of this, and how do we gather that information practically as we go about our business? Is there any ways which you've come across?
Yeah, I mean there's tools out there, isn't there? And obviously the most widely used that I understand is the Rockwood scale. So actually scoring the patient using a frailty score at that point is a really good way of actually highlighting that this patient probably will need further assessment in terms of both their function and clinical presentation in terms of help to go home. So Rockwood though is a kind of a trigger for something else, but that works really well in environments where then the therapy team can become involved really, really quickly, or they're there actually taking the handover from the paramedic as well. So lots of areas now that the paramedic crews are actually they're actually recording a Rockwood scale as well, obviously, which is really, really helpful and a really good starting point.
And anyone could do a Rockwood score.
That's right.
Aren't they? So it doesn't really matter, nurse or therapist or paramedic or
So in terms of the next steps, you mentioned about a framework to helpfully remind yourself. What was that framework again?
So the therapists at Stepping Hill Hospital in Stockport, they came up with fresh conversations. So that stands for function, risk, equipment, support and home. And it's not a format or a model to work. I've lost it.
Like a prescription.
Yeah, it's not that. It's more of a way to frame the conversation. It's probably helpful then to break down fresh into its component parts and just give you an idea of each of the areas as to what the kind of conversations we'd be looking for or what might be helpful at that stage in the patient's journey. So thinking about function, that is literally how the person was observed interacting with their environment when the crew arrived. So it's thinking about how did they transfer when the crew arrived? Did they get onto the trolley themselves? Did they need help? Were they on the floor? Actually, what was their function like? But also thinking about could they follow instructions? Could they sequence a task? So it's thinking about their cognition as well. It's not just around their physical function also. But it's also being able to ask the patient or the person, actually, how have you been managing for the past few months at home? So really finding out about the context of the person. So has there been a gradual decline in their abilities, or is this a sudden onset? Has something just happened to them? What's their usual routine? Are they usually out walking the dog, or do they usually just do the stairs once a day? So they're practicing energy conservation. What are the types of things they do to support their function as well? So the next component is thinking about risk. And we've got to be really careful about this. We've got to really think about risk. And is there anything that the crews recognise as a risk within the environment? Not to stop discharge or to prevent anybody from going home, but actually to begin to mitigate risks and to make sure that any myths don't grow out of this either. So we know that often if an environment is described as cluttered, that goes on to then prevent the person going home. So it's making sure that we don't impose our own values and our own judgments on that person, but actually being able to cut things off at that moment in time. And also it's thinking about what risks is the person themselves willing to take to go home. That's a really good time to have that conversation as well. So they've been living in a certain way for a long time and they're happy to go back to that routine, then actually who are we to stop them? The equipment element is obviously self-explanatory. It's thinking about have they got any equipment in their environments already that actually helps them at home, anything that helps to compensate for them. Are there any major adaptations in place as well, such as stair lifts, etc.? So what is it at home that actually helps them? It's also a good indicator as to whether community services have been involved in the past as well. Something as simple as that will give you an indication to that. Support then is about thinking about what support is the person getting at home, and that can be informal care via a family member, or it could be a friend or a neighbour, who they are and how they support and how can they be contacted. So it's all of those things wrapped up into one. But also if it's a formal agency, it's the detail about who that agency is. Even if you've got the name of the agency, they're easy to Google and you can actually then start to contact them to say, expect your patient to be coming back home today. Rather than taking them into hospital because their care package might have stopped. So it's making sure that those lines of communication are kept open, and so that we're actually aiming all the time to get the person home.
Also, the care agency, Claire, often has quite a lot of information.
Absolutely, they do.
They're caring for the person, and they'll be willing to contribute, won't they?
Of course they will. I think it's also a good time to ask, is the person happy with the care they've been getting? Was it enough? Because often, at time later on in the person's journey, sometimes they'll say, I didn't like the agency anyway and I want to change agency. So we kind of have those conversations up front to say, actually, how are things going? So again, we can begin to mitigate that and start the conversation with social care if that's what's needed, or with whoever. And obviously the last letter stands for home, and that's about what's needed to get the person home today. So does the person have their keys? Do they have their shoes? Or do they have a coat? Is that something that we can actually achieve today in order to get them home? So it's things about transport and details around access as well. So it's just making sure that both the crews and the hospital are working together at that point to make sure that we can maximise our chances to avoid admission for that person if they don't need it.
That's great, and it sort of feels like it's relatively easy to ask these questions.
It really is. It's a really simple conversation that you can have with a person over a few minutes, and actually that conversation about home is a really reassuring one for most patients, because actually we're giving those real strong home first messages to both the patient and their relative at that actual moment in time, rather than waiting till later in the person's journey. So for me, it makes perfect sense that we start to do that and act at that moment rather than wait until later.
That's great, thank you.
You mentioned earlier on that it's not prescriptive. Does it have to follow that format?
No, not at all. This is simply just a way of remembering all the elements that you actually probably need to cover if you're going to get a comprehensive assessment started at that point in time, but there's no set rules to say you've got to ask questions around the environment, but I would honestly say that most crews will offer you information about the environment, especially if there's something that stands out to them as maybe an issue or something that's really impacting on the person at home. They tend to offer that information, which is really, really helpful.
Thank you. So teams could adapt it, Rob. I think that's what maybe we're asking, isn't it? Is that it doesn't have to be that. Teams can adapt it, but there are components of the conversation that are really important for the patient. But actually, how you gather that information is up to you.
It's absolutely up to the teams that are involved, and as I say, it's a two-way process, so it's the teams need this information to be able to act upon it, to prevent admission where possible or to start the discharge, but also for the person coming into hospital who's in crisis, for them to hear information about home, and knowing someone's proactively trying to get them back home is really, really helpful and reassuring.
Do you know what, I think that's a good place for us to almost finish, because you started the conversation trying to get people home, and you followed the patient's journey all the way through, right up to the very handover point, to gather the information that will enable that patient to get home. So in a roundabout way, we've started at home and we finished back at home, which I think is the
right place
the nub of the story. So thanks, Claire, thanks, Wendy.